हॅलो हॅलो येतोय ना. हॅलो येतोय ना तिकडे. हॅलो
Can you hear me as well? Okay.
So can you hear me?
Yes, I can.
Yeah. So
Oh, this was quite a challenge with WebEx. Okay.
yeah.
I'll just stay in here.
So you can keep your video off for some time. So once you can. Uh, so good afternoon, sir. Can you hear me?
I can hear you. Can you hear me?
Yeah. Yeah. Sure.
Is the anyway? I just logged in a few minutes early.
Hello?
Hello. Hello.
Yeah, hi Sanjeev.
Who's this? This is Sudhakar, is it?
Yeah, hi Sanjeev.
Oh, hi, Sudhakar. How are you?
I'm well, I'm well.
Good to see you. And from Rajurka.
Hello?
Yeah.
So can you hear me?
Yes, I can. Can you?
Yeah, I can.
Okay. And who's Saurabh Rajurka? Yeah.
He is from our admin team.
You're it. Okay. All right. So, Sudhakar, क्या हाल है? कहाँ हो? Where are you now? How is family? How is everybody?
Yeah, all well. I think everyone's recovered, back on their feet.
Okay.
And it was bacterial, but everybody freaks out these days with. So, but all well.
So, where are you when we speak now? Bangalore or Mysore?
No, now in Bangalore.
Bangalore. Okay. So we should catch up. Then you have
Yeah,
to.
sure, next week. Next week.
How's how's next week looking?
Yeah, looks good.
Looks good.
Because week following that I'm out, so let's catch up next week. I'll send something up on your calendar.
Okay. So if we have to do Monday, then try and keep it in the afternoon. Morning, I'm already busy. Yeah.
Yeah. Swapnil, do you know how many people registered? Do you have some metrics?
So usually we have around 120, 150 people attending this leadership dialogue. So as it started, we will get the count.
Oh, you don't know when they register, is it?
No, we have this overall register for we had this hospital tech event which was there for around 15 days, and we had around 3,000 plus registration done for that. So when these sessions are going on for this during this 15 days period, right? So every day for this session we are getting around 150 odd participants joining to this.
Has anyone else joined from the panel? Oh, I see Vineet. Hi,
Yeah,
Vineet.
yes.
No, you can see beneath. Huh? I can't see.
I mean, I see your name,
Hi,
Vineet.
Oh, I thought
hi,
you.
I'm there. Hi.
Huh?
Hi. Yeah, I joined early and I just switched off the video and I was on the mute for a while.
Okay. Hi. Good to see you.
Hi.
All
Hi,
well?
how are you? I'm very good. All well, all well, all well.
Okay. So
Vineet, how do you get that background? Is there an option here to?
Yeah, there is an option. Change the background.
Yeah, but I think I'll just because I don't use WebEx much.
Yeah, I also don't. So I just ensured I log in early and check out those features and switch them on.
I know sometimes people have those nice beaches, yeah, in the background. So I asked them, I said, "How are you taking it on a beach?" He said, "Oh, this is just a background. These are simulations."
Yeah, but you don't. Yeah, so that you can do in your uh, more what do you call not chats and conversations like this. So obviously you can switch on.
Mostly to so that people don't see the mess behind us.
Yeah, the safest is the blur.
Yeah, you look like an angel
With the hello, yeah.
with a halo behind you. Are you in Bangalore, Vineet, or you're in UAE?
No, I'm in UAE. I'm in Dubai. Yeah. So under the video, you have an option. Just if you click on the down arrow, there's an option to change virtual background.
Ah, okay.
You can just click on that, and it will then ask you to. The only thing is that even for blur, it's asking you to download. I don't know why. Anyway, so just click on that.
Yeah, but I don't like any of the blur and thing. Yeah,
So you can't do any of the others other than blur.
I can't choose the. Oh, this one worked. So do you see me with some?
Some pictures behind you now.
Do you see my same? You see that map and my garage
Yeah,
behind, or you see something else?
you
I
can see
can
the
see.
map. That's it.
Oh yeah.
Map in the garage. Yes.
Okay.
Oh, you only see my garage. Okay, didn't work then.
Good afternoon.
Yes.
I think that's.
Hey, Sanjeev and
Hi.
Sharif. How are you?
Hi. How are you? Good to see you. All
Good to
well.
see you. Yeah, how are things going?
All well. I know this was a difficult day for you, and thank you so much for squeezing the session out.
No worries.
So I don't know. So Swapnil, were you able to check with Professor Farizra?
Trying to call him, he's not picking the call.
Not taking the call. Okay.
I think it worked now. You see the virtual background now?
Let me also try.
Yeah, I can see that. Yeah, yeah.
Oh, so it worked. Okay. Okay, good. Hi, Sharif. This is SJ Sudhakar from Zebra.
Hi, good afternoon.
Good afternoon, Sharif.
I'm just trying to see if I can get Professor Farizra. No luck. So how you are in Bahrain, Dr. Sharif? Huh? As we
Yep, I'm in Bahrain.
okay. Okay. So any plans to visit India?
I don't know, travel is still a little bit iffy. So, I mean, at some point in time, yes, but we'll probably just wait a little bit.
Correct.
Just give me 1 second, I'll be right back.
Yeah, yeah, please.
Hi Sanjeev.
So, Professor, I've joined, Mr.
Oh,
Sanjeev.
hi. How are you? I was calling you.
Oh, sorry.
No, but you're just in time. Yeah. Still, we have 2 3 minutes.
Yes,
Good. Hmm?
everything is okay. How about you?
Good. As we speak, where are you? Are you in your office?
I'm in
No.
my office.
Okay, but the background looks a little different from what I saw that day when we met. No?
Yeah, no, it's the same background.
Same background. Okay, you have that nice, beautiful monitor is on the left hand side.
It's the same monitor I'm speaking from.
Okay. Oh, okay. Okay. All right. Good. 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 So we had everybody here. So just now, Dr. Sharif has, I don't know, stepped out, and I don't see Mr. Vineet suddenly.
No, they're both here.
Where are they? I don't.
They
Why
got
don't
right here.
I see them on my screen? Or do I need to do something to my screen?
I think go to that floating view. You will see everybody on grids.
What is it floating? You just let me get my expert. Varun, come. I am not the smartest of the tech guys. How is big here so that I can see everybody. Yes, now I can see everybody, and I can see Dr. Sharif. Full blow. Good. So, Swapnil, you are the first. You have to tell us when to start. I think everybody's here. Swapnil?
Sanjeev, echo. Do you feel the echo when I speak as well?
No, I don't see any echo, but you
So,
are getting an echo when I speak.
Yeah, there is a little bit of an echo there. I don't know.
Yeah.
It's like a feedback echo
so,
type of thing.
so that is because the multiple mics are on. So may I just request if the panelists are now speaking, they should keep their mics on mute. So the echo. So we are live now. So we can start with session in just a minute's time. So I'll just thank you, Mr. Sanjeev, for curating this session of healthcare leadership dialogue, and thank you all the panelists for joining us for this leadership dialogue. And so may I now request Mr. Sanjeev to take it forward. Thank you.
Thanks, Swapnil. Thanks a lot, and welcome everybody. I must tell you one little disappointment is Mr. Joy Chakravarti is not able to join. He had a last moment emergency and he had to step out. Though he did say that he will try to join in, if possible, by the end of this, before the end of the session. But he said, "Don't be disappointed if I don't join." And we know healthcare is all about emergencies, and sometimes you just can't manage it. So he is not here, and I am personally disappointed because he's not only a friend, he is the one who's the man behind and in front of all these shows, and it would have been great to have him here and deliver his keynote address. But that's it. I also, before starting, I want to thank CII actually to give us this platform and an opportunity to interact. Uh, I think without their blessings and their support, this wouldn't have happened. So, Swapnil, thanks to you and your organization for organizing all this for us. So, without further ado, and I know we have 1.5 hours, but I'll tell you, 2 days back, actually on Wednesday, I had organized, again, I was the moderator, and I had organized a session called Research to Reality. And suddenly you wouldn't believe that, I thought we had 1.5 hours and we ran out of time. And at least two of the participants could not get more than 5-7 minutes each. That's all. So I was very disappointed, and I thought I'll make sure that next time we don't do that. Of course, just to share, the theme was research to reality. The panelists were Dr. Ajay Kumar from HCG. We had Vishal Bali from Asian Healthcare Holdings. We had Mr. Santosh Mishra from Secretary E-Governance from Tamil Nadu. We had Dr. Sujay Kar from Apollo Hospitals. And we had Mr. Prashant Gupta from Microsoft Corporate Research. So, with due respect to everybody, these two gentlemen in the end, Prashant from Microsoft and Sujay from Apollo, didn't get much time. And these three heavyweights, of course, they made it very enjoying the whole session, and they were very intense about whatever they were saying. But yeah, it left those two people with very little time. And as a moderator, was feeling guilty at the end of the day that I didn't do a good job. So I'm hoping that we will make sure that everybody here gets almost equal opportunity to share their thoughts, and that's it. So that was one point which I thought. Second point which I also wanted to say in this context was that I think we couldn't have had this subject taken up at a better time, at least from an Indian perspective. I don't know how many of you are aware that there is this event called Raise 2020 happening in India. Are you any of you aware of it? Fanindra ji, Mr. Fanindra, Professor Fanindra was definitely no, isn't it? No? Yes?
Yes,
Yeah.
yes, I know.
So, but just for the benefit of those who are not aware, RAISE 2020 stands for Responsible AI for Social Empowerment. This event is a Government of India led initiative, which was opened on Monday 5th evening, less than our Honorable Prime Minister Modi ji, and starting from him down, Amitabh Kant and Law Minister and Information and Technology Ministers, everybody was there. So it started on Monday evening and is continuing till now. Today is the last day. 4 days, all on AI. And of course, while the theme obviously is talking about responsible AI, but yeah, it had a lot of other elements of AI in that. So from that perspective, I think there is a lot of sensitivity, there is a lot of understanding on this subject, and everybody understands that this is absolutely a must subject for everybody to understand and uh, play their roles in it. We all know the terms like AI is the water or electricity of the future or oil of the future. These things are going around, but yeah, it is on ground really making a difference, or at least there are a lot of people who expect a lot from it, and there's a lot of focus on it, and a lot of hopefully funding also will be coming in this direction. Yeah. So with these two broad points of research and reality session 2 days back, and raise which is ongoing in India for the last 5 days, I now wanted to come to our topic of AI hype, hope, and fear. And also, I must make a quick confession, if I can call it, that this is not my term. This is not my terminology. I was fortunately present at the RSNA of last year, 2019. I'm sure some of you know that this is an event which happens every year, November and December time frame. And during the plenary session, which was the opening day of the conference, there's a presidential address always. And this time, the presidential address was given by, and I was personally, obviously, and we as Indians were very proud of the fact that the outgoing president was Dr. Vijay Rao, ex-lady from AIMS, and now, of course, in US. She was the president of Radiology Society of North America, and she delivered this keynote or the presidential address in the opening plenary session. And the first slide, when it came up on that, was this: AI, hype, hope, and fear. So I have, in some sense, stolen this idea and this thought from there. And of course, she went on talking about it for almost 1 hour. And that was, I think, great experience and learning for me. Now, coming today, my thought was that while that happened in November, December 2019, I just wanted to check, has the world changed dramatically, or these three sentiments are still as valid as they were last year, or if there's been any tweaking or changing, how is it? And all of you, what is your take on this? These are three very critical sentiments, which, if it come from no less than radiology RSNA president herself 1 year back, I'm sure these are serious sentiments and serious thoughts and require serious consideration. So this is the background of this session now. And while, of course, there is no, means we all are free to come in and say whatever we want to say, but to at least get the session going, I was thinking I would request Dr. Sharif to come in first and share his thoughts at a high level on these three sentiments, and then we will go around. Yeah. Over to you, Dr. Sharif.
Thanks, Sanjeev, and thanks for having me on here. Actually, when you invited me first, I thought, why are you calling me? Because I'm not really an AI expert. I'm not a technology guy. I'm just like, I'm a doctor who likes technology. And that's the way I look at it overall in terms of adapting any technology, whether it be AI or any other form of technology in our hospital setting. I'm still a practicing doctor. And so I want to, what I feel is that healthcare and healthcare delivery is vastly inefficient. When you go to the doctor's office, you spend half the day there, or sometimes you go to the hospital, you spend the entire day there, and it's frustrating for a patient. And at the same time, there are probably frustrations that I'm feeling as a doctor. And I think technology is great when it works for us, but when we have to work for technology, I think it is challenging. I was at a conference not too long ago, and it was on digitalization and things like that. And someone asked one of the panelists, "What's the greatest obstacle for implementing technology in healthcare?" And they said, "The doctor." So I had to argue with that and kind of profusely disagree with that because, you know, as a doctor, I'm probably pulled in multiple directions at the same time. I'll give you the prime example of that. And, you know, 25 years ago, I was practicing in Michigan, and one fine day, they said, okay, you've got to now enter into the computer your electronic, your record. It's going to be electronic, which was great because I could never find the record when the patient came to visit. And I thought this was a great thing. And I started typing, and you know that has its own challenges. I'm not able to be as productive when I'm seeing patients. Much easier to write, but I think over time that definitely has a benefit. And that was in the early stages of electronic medical record. And there's still hospitals that are trying to implement an electronic medical record, but it's a necessity in terms of patient safety. But at the same time, it is a little burdensome for the doctor. And now the doctor is also told, well, you know, you have to work on, you know, your patient experience and your patient satisfaction scores. And so here I am buried into a typewriter trying to talk to the patient, and I'm supposed to interact more with the patient. So, you know, that has its challenges in terms of implementing technology into my workflow. But the way I look at, you know, AI and some of the changes that are occurring with technology, you know, wouldn't it be great? And maybe there are parts of this technology that are available now. But, you know, for me, the way I look at it is, wouldn't it be great if I'm sitting with the patient and I can really focus my attention on the patient and interact, engage with the patient, meaning make eye contact and so forth with the patient. And I don't have to worry about typing into a computer. That whole interaction can be recorded, and then using technology, using AI, converting that into a document for documentation and medical legal type of purposes. And if I say, you know, I'm going to start you on this medication, a prescription being generated out of that using AI. And so that's what I'd like to see in the future. And I think that'll make a great efficiency within healthcare, at least for me as a doctor. You know, we're using some of that already. You know, in our own system, we have these conversational chatbots, and that is a form of AI where a patient comes onto our website. They say, you know, I have abdominal pain, I'm vomiting, and it goes through symptoms. And then the chatbot will recommend that this is, you know, this is who I recommend you see, and may give you based on your symptoms, may give you a recommendation of a surgeon or of a gastroenterologist, and then the chatbot can help you make the appointment. So that's a form of AI that's already out there. It's easy. It's being implemented. We've implemented it. And Sanjeev, feel free to cut me off anytime.
No,
Just to go ahead.
no, it's too early to cut
Going,
anybody off. Please
yeah.
go on. Yeah.
So, you know, the other area that I really find frustrating as a healthcare provider and as a CEO is that there's a lot of inefficiencies in terms of insurance. And healthcare and insurance companies are always kind of butting heads a little bit. I come in, a patient comes in to see me, they have one insurance form, I have to document in the electronic medical record, then write it out on the insurance form because not all the insurance companies are on a electronic portal. So all of these challenges occur, and it affects my productivity. At the same time, it affects, you know, my interaction with the patient. So one of the things that we've done is taken basically bots and taken things from our electronic medical record and put it on the insurance form in a sort of robot process automation type of situation. And then those companies that have an online portal, we are able to submit it in an online portal. And those companies that need to submit it in paper, it gets printed out and it gets submitted in paper. So I think that's really helped me, and it's helped my doctors. So some very simple things that we're able to do. And then obviously on the other end is rejections. I mean, my revenue is an insurance company's costs, and so they're going to try to keep their money, and I need to try to get money for services that my doctors, that our doctors have provided. So the same process, we're able to check what we're submitting so that the appropriate justifications are there, so that we don't get rejected. So it's almost like a rejection pre-checker before we submit it onto insurance. So now we're actively doing this. I mean, we as an organization, we're spread over 6 countries, India and the Middle East countries. And so in the Middle East, there's a tremendous penetration of insurance. And so it becomes very important. And although not as much penetration on the insurance side in India, it will come. And these sort of changes will be faced by healthcare organizations in India. And I think we need to be prepared for that. I'll just pause there for a second.
Okay, great. So for the, I don't know, just to save some time, I didn't introduce you to everybody and kind of assumed that everybody would have read each other's, kind of a profile. I see some echo coming. Where?
You.
You are, okay. So I didn't do it, but I think I should say that, Dr. Sharif, for the benefit of everybody, Dr. Sharif is the group CEO of the KIMS Health, and which has operations both in India and Middle East. So that's where and as we speak, he's speaking from Bahrain. So yeah, we will pause, Dr. Sharif, you for a moment, and then let's go over to Mr. Vineet, who is the group CIO of Aster, again spread across India and Middle East. And he's based out of Dubai. And as we speak, he's taking this call or he's joining this meeting from Dubai. Then let's see what he has to say on this subject. Mr. Vineet, over to you.
Thank you, Sanjeev. Thank you, everyone, and thank you for CII for having me on the panel. Like, very interesting topic, and like Sanjeev, you started off. I just hope 1 hour, 1.5 hours is good enough for this. So just going on, just where you left off, saying whether the hype, hope, and the fear. I would maybe just touch upon each of these and how these three relate to this the whole AI discussion. Hype, just like any new technology that comes to market, there is a hype. There is a whole lot of hype when it comes to any new technology, and I relate hype to too much being said about a technology with too little known about that technology. That's when the hype comes in. But hype is, for me, is also about managing expectation as to what can be done now, what can be done a little later, how much can be done now, and how easy to do now. All that falls into the hype. And if there is no hype, there is no fun. So the hype has to be there for most of these. And hype really helps all of us like practitioners to make things interesting. So I have no problem with hype, but there is hype. I'm happy with the hype. Hope, there is a lot of hope that because I keep saying anything that we bring in, like Dr. Sharif mentioned, the whole way in which healthcare is practiced and brought in is become, if you look at any other industry, unfortunately, we are Stone Age. If a retail can do it, a banking can do it better. How on earth, why on earth will you not use it on healthcare and make the whole experience better for people? So hope is all about that, and hope is all about using technology the right way. And I'm so happy that Dr. Sharif called himself as a doctor who loves technology, and I agree with him when he says that people definitely use it very wrong in a wrong way when somebody says You're not able to implement EMR because the doctors don't support it. The doctors don't support it because the EMR is not good enough, because it's not easy for to use. It's not good enough, in simple words. So the hype and the hope and the fear obviously comes from the fact that, again, related to the hype, perhaps because hype also brings in a lot of jargon, a lot of things that is unknown, and the usual discussions where you hear people talking about humans being made redundant with robots taking over, and the whole lot of sci-fi, right? But the fact is that it is not here to replace anything. It is not here to bring any unemployment. I always put it across that saying all the use cases that doctor mentioned are all about making humans more efficient and being able to do better things than mundane stuff. So I would put it that way to anybody who is saying that, saying, why are you afraid of it? Because it's taking away all the unnecessary things that you're wasting your time in. Spend better time with your family and friends and do good stuff. So that's where you replace technology. So I say hype, hope, fear, all good, and all can be put to good use.
And all relevant, all are relevant
All
given
relevant.
the context. Yeah, sure. So thank you so much, Mr. Vineet. And now I would go to Dr. Fanindra, who knows it inside out. He knows the reality there. He knows the fears. He has no fears, according to me. He's the one who's generating it. These are his babies. He's creating, and he knows exactly where they're heading. So nothing like having a person like Professor Fanindra on the panel, who is the creator and who knows what it is heading for and what is he creating. He is the associate professor from Institute of Science, and he comes from the Department of Supercomputing. I have known him personally over the last couple of years, and he, besides his technology part, is very fond of healthcare as a subject and is very passionate about it. So while he will talk about AI, I'm sure he will talk health as well. So over to you, Professor Fanindra.
Thank you very much. Thank you, Sanjeev, for inviting me here. Thanks, CI, for having me on this panel. I completely agree with Sharif and Vineet on all the aspects. Just to give, a little more better perspective on this, what both Sharif and Vineet were talking about is the complexity of the patient care currently we are in, both from the technology point of view and as well as from the doctor point of view. Doctor is worried about entering the data into the computer. From the data point of view, we are worried about whether doctor is entering the right information, whether we are able to get the right information, whether there is noise in that in terms of our own technology for the AI. But just to reassure everybody, what I know for sure is that health and healthcare are too human, and AI cannot alone cure it. So today I put AI as good as a laboratory test, and it has to go through all the tests which has to come. Any laboratory test will have a hype. It'll also have a hope. It'll also have a fear of failing, like COVID-19 vaccine. It'll have a hype, hope, and fear, right? So everything else is going to happen in that space. And ultimately, medicine is always about evidence, and medicine is always about improving the lifestyle. So unless we do both of them, I don't think we will survive. AI will survive, and it's only the time which can do that. But of course, we should have that hope, and we should do that. And as technologists, we are very hopeful that we will be able to tackle the complexity of the healthcare which is today. And as already mentioned, so it should reduce all the labor cost and bring more efficiency, such that more people will get into it. This is called as democratizing the AI and democratizing the healthcare, such that the cost will reduce overall once the machine starts functioning better. And then you can bring in more and more people into the healthcare ambit, because there are a lot of people waiting out there to get minimum care. And we could possibly bring in all those people into the care. That is our hope. So that's where I will stop. Thank you very much.
Thank you so much, Professor Fanindra. I know you on this subject you would have gone on forever and on and on and on, and I'm sure you will come back again. But yeah,
Sure.
thank you for pausing now for a moment and letting Sudhakar Jairam, senior consultant from Zebra Vision, coming in. I'm sure you would have anybody who knows or who is interested in AI as a subject would have heard of Zebra. This is a company from Israel, Israelis in general are known for pioneering and innovating and research. Zebra is no exception. As far as I understand the landscape of companies working in the AI space, and I was at RSNA, as I said last year, there were 147 companies who were participating, and there was a separate hall created only for AI. I can tell you one company which really stood out there among 147, clearly lock, stock, and barrel above everybody else was Zebra, and I'm happy to have Sudhakar here as a senior consultant from there. These are the people who are kind of, according to me, while I'm sure they do their own research, but whatever happens in institutions like ISGs, I think they use some of it, productize it, and take it and make an impact to patient care, which is the last and the most important thing. So over to you, Sudhakar Jairam, and he's fondly called, or he says he prefers to be called SJ. So I call him SJ, and he's a dear friend as well. I can use that word. Okay. All
Thank
right.
you.
Over to you, SJ.
Thanks, Sanjeev, and thanks for having me on this panel. So I'm going to share some practical examples from my experience, not just with Zebra, developing these high quality, high performance algorithms across modalities, across disease conditions, but I'm also going to give you my view because prior to this, I was the CEO of several large hospital networks, both in the Indian subcontinent and also in China. So let me first talk about why hype. Yeah? I think the hype has, in my mind, nothing to do with the technology. The hype has to do with human beings because if you see the way we react, we always overestimate, overexpect, and overrate anything in the beginning, and we tend to underestimate it in the medium to short term, right? So just when COVID hit, we overreacted, overimagined, did these extreme measures when we were 100 cases infected, and now we are a million and we underestimated, right? So this is just our nature. And this will happen to new technology, it will happen to big events. And let me give you firstly a few examples of why I think there is hype. Firstly, I think there is hype because people see AI as some kind of capability, some kind of abstract capability that these machines have. And I think if we start focusing on use cases, specific applications, then that hype will start disappearing. Let me give you an example. So in the initial days when I started meeting radiologists, because we focus on AI algorithms focusing on imaging, I would go and meet radiologists and say, hey, we now have algorithms that can detect an intracranial hemorrhage, subtle bleeds, subarachnoid bleeds on a CT scan. Most of the time, a senior radiologist would say, that's okay, but no big deal. A junior resident can pick it up in a matter of seconds. So why do I need AI for this, right? So there is a sense of hype. But if I were to take the same solution to an emergency physician who is working in a messy environment, and most emergency physicians, almost 80% of them say that they experience diagnostic uncertainty on a daily basis. And if I tell this emergency physician, listen, I have this intracranial hemorrhage, if you have a trauma case coming into your hospital and you have this algorithm that's detecting this, he's going to love it. So I think it's a question of trying to use relevant applications in the right area. Let me give you another example, right? Today you have so many algorithms which say, I can tell you whether somebody is COVID positive or COVID negative, right? There are a plethora of algorithms, both on chest x-rays and on CT chest. Now, when I think about it, it's actually useless, right? How does it help a hospital if I were to tell you somebody is COVID positive or negative based on an image? So, but if you were to just extend it a little bit and say, doctor, not only can I tell you that this person is positive or negative, but more importantly, I can segment the disease in the lungs. I can then quantify what percentage of the lungs has been affected by COVID, 50%, 60%, 70%. And then based on this quantification, you can then determine whether this person should be in a ventilator, in an ICU or something. Then you're actually helping them use valuable resources, precious resources in a careful way, right? So again, it's a question of how you apply a particular solution. Now I go back to the senior doctor to whom I went to, let's say with the intracranial hemorrhage. If I were to tell this doctor, I can detect nodules on the lung, on a chest x-ray or on a CT, but not only can I detect, I will also tell you how that particular nodule has evolved over a period of time, if I had access to the patient's previous images and data, he would love it, no? Because it's going to be such a difficult, tedious, menial task for a doctor to be measuring volumetrics when the doctor should be focusing on the why and the how of the disease, not necessarily the what. So I think some of this is causing the hype. The other reason the hype is being caused, Sanjeev, is because of technology companies. Technology companies are product centric, right? We have this thing that here is my solution, now tell me what is the problem. Right? Most technology companies has this problem. You have a hammer, everything looks like a nail. So you go back to what Steve Jobs said, right? Steve said, start with user experience, start with the customer experience, and go back to technology. We don't tend to do that. You know, Dr. Sharif beautifully mentioned about EMR. It's a trauma. All EMR implementations that I've seen is a root canal operation. You hate it. You've basically converted doctors into highest paid clerks. You know, putting a keyboard in front of a patient. I mean, it is so obnoxious. No medical student, you actually do a work study, Sanjeev, and see how much time a doctor is cracking away on the keyboard. It's horrendous. And another reason why there is this problem, having been a CEO, I can admit, in almost all the hospitals that I've operated, there is always a trust deficit between the management and the doctors, right? The doctors are concerned about safety and quality. Management pays lip service to quality and safety. I'm not saying it's not important, but for me, if I was the CEO, cost, revenues, efficiency, and regulatory stuff like removing variabilities are way more important than safety and quality. I mean, it's the reality of the business. And this causes another alignment issue because doctors say, you know, I don't trust the management. And rightly so, because the doctors have been largely disempowered. You know, doctors have no budgets, they can't really make decisions. And I think a combination of all of this is actually creating the hype. Where I see the hope, I think AI is different.
Well, SJ, if I can interrupt you here. Here we have on the panel a CEO, management, as well as the doctor, Dr. Sharif. What do you think? How do you think he's handling it, both the sides? From
So
your
I
perspective.
have to applaud SJ for his comments. I couldn't agree with you more. I mean, we've taken the highest paid employee in a hospital and made them inefficient with some of the things that we're asking them to do. Again, I'll come back to, I think that's where technology needs to work for us to make us more efficient. You know, one of the things, you know, as a med student, you study differential diagnosis, and differential diagnosis is basically it's a pattern recognition. You have a constellation of components in the history, in the physical examination, in the diagnostics, and then based on that, you come out with a differential diagnosis of what you think the patient may have. And in some ways, what we're seeing with what's coming with AI is basically these algorithms or pattern recognitions that we used to go through as med students to come up with the differential diagnosis. So there is a science to medicine. There's also an art to medicine. And I think where AI is going to help the doctors is in that science part to help those components of that pattern recognition. You know, sepsis is a major problem in hospitals, in emergency rooms, early diagnosis of sepsis. And there are a lot of initiatives about sepsis, and for those who don't know what sepsis is overwhelming infection in the body. But there are parameters in your history, in your physical diagnosis, in diagnostics that point towards sepsis. So machines can alert and extract information also from the electronic record to create an alert to doctors or healthcare providers that this patient can have potentially sepsis. So it becomes an early diagnosis. So I think all of these components help the provider. It's not that AI is going to get rid of doctors, but AI is going to help doctors work more efficiently, make earlier diagnosis, help with that pattern recognition, and at the end of the day, have a better clinical outcome for the patient.
Exactly. I just wanted to reiterate what Dr. Sharif said, I think AI will do two things, right, despite the hype. Number one, it's going to make the doctor patient relationship more human. And I'll tell you why in a second. And number two, it's going to make doctors more human to themselves. You know, if you look at doctors, they're getting burnt out. 50% of the doctors will probably not choose medicine as their career if they were to choose again. 60% of the doctors won't recommend medicine as a career to their children. And these are real facts. They're getting burned out. And I think AI can help with that stress. So if you take a radiologist, right, an average radiologist sees about, let's say, 50 CT studies a day, right? You take a CT, it spits out almost 1,000 images per study, right? It goes chuck, 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 those coaxial images. So if you see 50 patients, you have to see 50,000 images, yeah? And there are, in an 8-hour shift, you don't go to the bathroom, you don't have lunch, you don't do nothing. It's 28,800 seconds. So the doctor has less than a second, yeah? It's humanly impossible. And this is where I think AI can focus the doctor on what's important, right? Because 20 years ago, if radiologists looked at 50 cases, 80% of them would be abnormal. But today, it's scanning all over the place, right? Janta is doing scans. In COVID, I'm seeing CT numbers have just gone through the roof. So you have more normals. So I think AI will help focus the doctor on what is important, what is acute, and this is where I think it will start making a big difference. And the second is if it starts not just detecting, but also segmenting. And to the last point, and I will stop after this, is to what Sharif said about pattern recognition. Right? Look at a junior doctor. How does a junior doctor make a decision? They refer to the book, they make a differential diagnosis, there is a rule-based system, and then they look at, okay, what are the other possibilities? And then they come to a conclusion, right? But for a moment, if you look at, I'm just going to give you a parallel example. I saw Vishwanathan Anand, our chess prodigy. I saw him playing with like 50 players, yeah? He's like going from one desk to another desk, and he's just playing. And there are like 50 players on the other side, right? Now, do you really think Anand is like seeing each chessboard and, figuring out moves sequentially? No, he's seeing a pattern, right? This guy has done it for so long. He's such a prodigy that he sees a pattern. And this is exactly what happens with doctors when they become experienced. They don't need to see images. They will tell you with the sound of your throat. They will recognize a pattern. So now what is happening is AI can become an expert in 2 months. If I can feed 500,000 melanoma examples, I can put 500,000 osteoporosis or cardiovascular example, the AI is equivalent to a doctor who's like 30 years, right? You can't deal with this. You can't compete with this. And therefore, I think you take the AI to say, what is wrong? See, today the question is, what disease does the patient have? This is the question. AI will change this to which patient has this disease? Patient is out of the equation today. We are only focused on the disease, but now with AI, you can actually get to the patient. And I think that is where the hope is as far as AI is concerned.
So SJ, let's pause for a moment. Now that we are heard the expectations, the frustrations, and Dr. Sharif and you, and I'm sure Vineet have certain expectations from AI to address the ongoing issues around the world. Let's go back to Professor Fanindra. And are these guys imagining? Do we really have solutions? Are you working on something which is really going to come out and address all these issues, or these have to wait forever?
So I think we, as already mentioned, right? So we have a lot of hope around it, and saying that this might solve the problem. But
no, but Professor Fanindra, I'll tell you one thing. Being in businesses, now you hear this term called hope is not a strategy.
Yes,
it's
it's
good.
not a strategy.
Correct. So we have to go beyond hope and see what's going to come out. Yeah.
So see, again, I can only tell you that till now, what technologies have been really rolled out have been only what I call it as a specific solutions. So that means that it is able to do one task, two tasks, three tasks at a time. It is not a radiologist. Radiologist can look at hundreds of cases and possibly do differential diagnosis of hundreds of diseases. Most of the current AI technologies are for differential diagnosis of maybe at max 2 or 3. Of course, there is something called as decathlon. We are all working towards it such that we become as good as radiologists. But I can tell you the other way around, right? So tomorrow, this is my take of this. We were talking about EMR, and today there is a lot of PHR. I mean, I'm talking about EHR, PHR information, which patients are themselves are generating using Fitbits, or you call it as Apple Watch. There is a lot of personal information that gets into it. But tomorrow, the radiology itself might be out of the question. If at all assume that he is going to do it, and all the doctors might sit, right? So each person from each of the sections, starting from pathology, radiology, they might sit and make one decision, right? So
Sanjeev suddenly is worried. Radiology itself is out of.
because right now what is happening is that currently the radiologist has one job to do, that is to do this differential diagnosis for something. And tomorrow that might be out of the picture because AI can do the differential diagnosis for one or two. But having said all this, we have a problem, right? So in terms of many of the things, as people told, we want to have 500,000 images to get into this. Where are these 500,000 images? There is a big class imbalance, right? All of them are normal. Where are the abnormality? The cancer incidence is 0.001%. How many cancer cases you get per day? Right? So those are all very, very low numbers. And that one case which you wrongly diagnose is going to take your organization down because of compliance. Correct. So right now you are leveraging on the doctors saying that, well, it has been done by humans, blah, 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 but who will take the ownership? Today, can you say that it is because of the scanner which gave me the wrong data? Will you say that it is because of the algorithm which has been wrongly trained? Can we say that it is because of the protocol which has been prescribed? So there is a big ethical issue. That's why the social AI, democratizing the AI in some sense, has a lot of complications in the healthcare. That's why it is still not taking off as we hope, because there are lots of issues which has to come up. And these are not easy questions. These are not really solved in a single day.
think,
Look, Professor Fanindra, now just one moment, SJ, one moment. I want to go to Mr. Vineet now. That he's heard academia, he's seen industry, and he's heard the doctors and the patient side of the story. How does he manage? How is he going to manage or plan to navigate or negotiate between these three, stalwarts, or and kind of negotiate and manage and give the hospitals and the patients and Dr. Sharif what he needs.
So it's simple, Sanjeev. It's like I think SJ mentioned, or I think, well, I don't know whether it was Dr. Sharif who mentioned. You don't go with the technology and then say, here is a toy. Can you see how you can use it? That's not how technologies should be working. You should be looking at the problem and trying to find some solution that can fit in. So if there is no use case, if there is no real use case, don't waste your time trying to put a technology into it, because it's going to be a written down. It's clearly a clear failure. So there are clear use cases, and there are all these what we heard. There are, whether it was SJ and Dr. Sharif also mentioned, there are clear use cases. It's only that some of these are still in the early stages of maturity. Some of these have to be tried, tested, and not in a state where it can be straight away brought in, if I may use the word, into industrial usage or put into a hospital and used directly. And at no point is anybody, I guess, I'm sure SJ will also agree with me, nobody is ever saying that it's going to replace any of the things or radiologists or doctors. We only that's not going to happen. I'm a firm believer that's not going to happen. I remember before coming down to Dubai, I was on a debate where many of us CIOs were on a debate on whether if robots versus humans, will humans be out? It was the famous Elon Musk versus Mark Zuckerberg discussion, which was taken up by the CIOs. But so I'm of the firm believer that it's going to only complement what we're doing. There are so many things that we are that's happening around where the technology is going to definitely complement us. So from my perspective, the right use cases, working with the clinicians, and trying to find how you can use them rather than just trying to find a place, trying to fit in a technology. That's how I see it. And one more point just to add is exactly what I heard multiple times is that it's about how you can make the life simple for doctors, like the multiple images that he sees. How can you make it simple to bring in just the relevant ones in front of him so that he is used to manage exceptions, and take it from there rather than the doctor spending time looking at billions of images. I hope that answers your question, Sanjay.
Yeah,
SJ, you want
sure,
to say
sure,
something?
sure. No, so
Uh,
just before SJ you come in, I just want to comment on what Dr. Sharif said in the beginning, and SJ also talked about EMR. And I'll tell you my take on this from a research to reality. And that's something which I keep talking about, I keep thinking about. Like I said, I was at RSNA last year, which was 2019. I was at the HIMSS in Florida in 2016. HIMSS is all about, IT, nothing else. Like RSNA is all about radiology. Like here, I said Dr. Vijay Rao, who was the president of the RSNA, gave the presidential address in the plenary session. HIMSS 2016 opening keynote address was given by the CEO of Walgreen Pharmacies. And I'm sure all of you here know Walgreen and their dominance in pharmacy and in US. This person was a doctor, and he had the attendance or the registration for that conference was 47,000. And in that hall, at that point of time, there were more than 5,000 people sitting. They were all IT guys. And here he was, his opening remark was, this EMR, what you guys have created and expect us to use, is a shame on you guys. He said, this shows and exposes your incompetency, expecting us to push the buttons because you cannot create enough cameras and sensors and systems around us to capture our patient and doctor interaction and leave us to concentrate on it and then push the buttons. This was his opening remark. In the midst of thousands of IT guys, he really hammered them. And he says, do not expect us to compensate for your incompetencies and your, this. Please get your act together. Let us focus on the patient and do not distract us from there. Do whatever you want to do around us in this room or where we are sitting and consulting, and leave us alone. This was 2016. My worry is, and I'm sharing it with all of you here, is that come 2020, 4 years later, and 2019, when I was at RSNA last year, I was trying to check how far the technology had moved to address this issue of the doctors and physicians when it comes to consulting and the distraction this EMR gives to them or leads them to. The sad part is it's still somewhere on the drawing board. There are very, very few companies which are working on this, and there are very few hospitals where it has been even put as a prototype. So if that is the pace at which things will move or are moving, I don't know where are we heading. So is AI going to be another one of those things, which will take all its time to make a difference to the doctors' lives, and ultimately that all that translates into patients. So I just thought I'd share this with you. Now, SJ, I know you've been wanting to come back. Come.
No, I wanted to respond to Professor Fanindra, but before that, I'll just quickly mention what you said. I think there's a big difference between EMR and AI. Now, because AI is basically computer science, the field of computer science, the solution is clinical, right? So, what are we doing? We are detecting, then we are segmenting the disease, we are quantifying it, and we are classifying it, right? This is what we're doing. It's completely clinical. It's not a technical solution, so to speak, right? So, you're not, so this is why I think CIOs like Vineet will enable AI with clinician leaders, whereas CIOs like Vineet will actually design an EMR. So I think EMR and AI are like chalk and cheese. As far as I'm concerned, AI is a solution to the problems of EMR by, you can take away the keyboard with a smart speaker or a smart listener. And I don't know if doctors would like it. So anyway, that is just to address what you said. I just wanted to say 3 points to Professor Fanindra in terms of why this is way beyond what we are thinking. This is now real. 2 months ago, 2 months, I don't know, maybe, yeah, just a few months ago, in the US, we now have CMS reimbursing for AI detection. So if a hospital uses an AI detection tool to pick up, let's say, FFR of the heart, fractional, FFR in the heart, or an intracranial hemorrhage in the brain, you will get paid about $1,000 or something in addition to what you get paid. So you're talking about a situation where AI detection is actually getting reimbursed. Now, if that happens, hospital is getting paid, radiologist is getting paid, patient is getting detected earlier, it'll fly. I mean, end of the day, it's about the money, right? I mean, so when when this kind of support comes in for AI, it will start happening. Second, I think we are making too much about AI. The analogy I would like to give about AI is look at it as two things. You use Word. In Word, you have an autocorrect option. So you type some stuff and you want to send an email to somebody. You use the autocorrect option and take care of your spelling mistakes like this. AI is no different. Yeah, I mean, we're trying to make too much about a small tool as if it's going to take us away. It cannot. And the second thing is think about AI as an autopilot in a flight. Right? So you have this long transatlantic flight. If I tell you that AI will fly this plane, you don't need a pilot, you're not going to be happy, you're not going to be comfortable. But if I say the pilot is there and there is an AI pilot which is assisting this pilot on this long journey to take off carefully, land carefully, and also manage turbulence, you're okay. AI is just a tool, and we should not make too much about this and just use it for specific use cases.
So, SJ, I hear you loud and clear, but as we understand and everybody knows that the rock bed of AI to be successful is data and good quality data. Now, I would take this to Professor Fanindra and let him respond and come in as to have we really got a solution to the data problem? What is his thoughts on
I'll wait for Professor Fanindra to say, I have some views on that.
Correct. First, let him come in here.
Yes. So let me tell you something, right? So I can only give examples of what I know. We work on recon, so image recon is something which I'm sure all of you use it. And let me tell you something, right? So he was mentioning about reimbursement for the AI, right? So that comes as a software as a medical device, SAMD, which has a lot more accelerated process because of the lobby which is there. So if I have to put SAMD as a really strict compliance as a lab test, it will never fly. Right? I know FDA 501K, how it happens for SAMD, and it's entirely a different process altogether. And Sanjeev, you know better than me all these processes, right? So that is number one. Number two, let me just say that the greatest fear right now, what I have is that we think that we understand AI. In reality, we don't. It's a black box. Even for people like me, we work on this. Explainable AI is a big topic. Right? So there are thousands and thousands of papers that are coming out to explain the results of why such an algorithm is working or not working. So that means we don't even have a handle, right? So when I come back to the something like what I was talking about on the recon, for example, like fast imaging has come in. This is called as compressive sensing in our world, where we work on sparse recovery of the images, where we collect less data and then try to reconstruct better by fast imaging. The MAP paper, the first paper on the fast imaging or the compressive sensing has come out in 2008. It has a nice, beautiful mathematical theory, and I can explain it on a board. It is a theorem and a proof. Those of you who come from the mathematics background. So that is very explainable. Today, AI is not explainable. I can't put like a theorem and a proof. It is all what comes out as what I call it as heuristics, or most of the people who love mathematics call it as heuristics. So it is a model which is existing, it is working, and I have no problem with that. Some of the technologies are meant for creating some solutions in that way. So I have no problem that it will work or it will not work, it will not do anything. But to make it as a big impact, what I'm telling is that if you want to use it as an adjunct, it will work beautifully. Adjunct is what I think works as the best. It's where you are combining intelligent analytics, which the system is bringing in, And then, for example, most of the time, Dr. Sharif will tell you, maybe somebody is explaining their condition and Sharif is looking for one word about their condition, which rings a bell for him, and then he makes the diagnosis like this. Maybe that word is what needs to be fed into the AI system, such that it will also make that kind of an agent, right? So that is what you are talking about. I think most of the time we are talking about increasing the efficiency, but in my view, it is not efficiency not related to only radiology. It is going to go past all this, right? It's going to increase the efficiency of how we are doing MR today, how we are doing data transfer today, how we are doing pathology today, how we are doing normal laboratory tests today. It's going to cut across all the disciplines. And it's going to come as an integrated solution like what you have like HL7 or, even for that matter, HIL system, RIS systems. So it's going to come as that, as one single integrated system, which can have all these components as built in. But it will do one thing for all.
But coming back to and staying with you, Professor Fadindra, is that if data is the rock bed of AI and the machine learning, where is the data or the quality of data?
That is a big question, right? So today, I can tell you, I can only talk about examples. Today we talk about atlases or what we call as templates. So we want to know what is normal to detect what is abnormal. And you can ask Dr. Sharif, can he define what is normal is? It comes from a large experience. What to define as a normal.
So let's park it here and let's go to Dr. Sharif. Dr. Sharif, come in.
No, again, it's as Professor said and as Estee said, the data, and there's a lot of data in our records, paper records, electronic medical records. It's basically finding those patterns within that data, being able to collect that data so we can make those, recognize those patterns. And I look at AI as a supplemental tool. So the stethoscope in the early days of medicine helped us hear heart sounds better so we could make diagnosis. So similarly, I think that's how AI is going to play in the future, is that it'll be a supplemental diagnostic tool that will help doctors with pattern recognitions. It'll help physicians become more efficient. But collecting that data, see what the output is going to be based on the input. You get good output in terms of algorithms if you have good input and the data points. And I think that's going to be where it's going to be a challenge, but AI should be able to, and we should be able to develop those things in codifiable documents so that those algorithms can be correct. I do want to just raise something to the panelists, and this is on, we've been talking about the hype and the hope. And I just wanted to touch perhaps on the fear of AI. I was reading an article some time back about how machine learning was able to look at, photos in people's Instagram and diagnose depression. And I found that, kind of fascinating. And they said the detection rate is somewhat around 70%. So in this internet world, when we worry about patient health information, when we worry about security, do you think that these type of things can be used against us? Can they, machine learning be predictors of disease? And all of a sudden I'm denied an insurance plan because I'm at risk of depression, or I'm at risk of cardiac disease because of something I posted on my Instagram. And is that too sci-fi, or is that something real? And I have to ask the panelists on that.
You ask me, it's real. I think it's real. I think it's happening. It will happen even more and more as we go forward.
So let me just come in here, and I just want to ask Dr. Sharif about this. We were talking about data, but today there is so much variation in the protocols itself. So let's assume that I have trained my AI model on what Dr. Sharif's hospital is giving me. So it is not easy to deploy it in Vineet's thing, because there is a huge variation in the protocol. Each radiologist or each hospital wants to have its own way of doing things. right? So it is not like one fits all, but it has to be done in some sense customized for each of the sites.
Let
And
me,
that is what is where most of the people work in that space.
yeah.
And coming back to this question about this being sci-fi, so this is a big problem, right? So what we call it as in the deep learning world, or we can call it as AI is deep learning is one of the subset of AI. Deep learning world is that you want to see the unseen. So the unseen could be that like diagnosing somebody with depression, just looking at their Instagram photo, and that unseen has a dangerous thing like denying something, or maybe even assuming that they are not fit for a job. You are talking about insurance. I'm talking about just as a job, right? So I can do that background check, right? So today you can imagine, right? A lot of them look at the social media data before even they hire them to know their details.
Let me respond to
No.
uh,
As you just so let's staying with data for a moment. I think data,
yeah.
and this I want to go to Vineet because Vineet has some thoughts on how to put that, and he's addressing the storage issues. He was at Fortis, he's at Astor. Before that, actually, Vineet, if I'm not wrong, you were with Airtel, na? Where were you?
Bharti, yeah,
Bharti,
Bharti
yeah,
Airtel, yes.
Bharti Airtel, yeah. So he has a tremendously, way. How is he looking at it from all those angles, yeah, about this data storage and handling and feeding it to the engine called AI? Vineet.
So I'll quickly address two or three things that got discussed in between. I know SJ also must have something like that. So
I'm sure.
one is that there is first of all, if that's the fear that we like I was just taking the last point that came up about the fear about how something could be misused. It just like stepping onto the road and being scared that there'll be an accident, because this is just one of those things that may happen, but there are so many good things that are possible with the system and technology that I will definitely take it as it comes. That's number one. Number two, for me, uh, I'll want to bring back the discussion saying data in a conventional way. When you talk about data, you talk about the what in our healthcare terminologies, it is the patient identifiable information and the patient health record, the PII and the PHR. But data is much more than that, because when we talk about data in the AI sense, it's about the vitals obviously is the PHR. It's about the location, it's about the geography, it's about the profile of the person. It could be the images. There are a whole lot of things that data that you be unknowingly also what do you call exhibit or exchange or give it out, which is all part of AI. So and when you talk about AI, there are so many use cases which we are unknowingly even now using, whether using a Cortana or whether it is you ask Google or you ask Alexa, it's all AI. So you've been using it consciously, unconsciously for a long time. So it's been there. So coming back to the data aspect, it is always going to be difficult. And as much as possible, I guess it's getting better now, because most of this data is getting captured by systems and sensors and enabled gadgets, as I may call it, and not being entered. So straight away, the errors are getting lesser compared to the earlier days when I would have started my role as a CIO, where it was all about forms, everything getting captured, written, and then there was a data entry operators and the whole lot of tech. All those days are a bit are gone, but I'm sure we still have that in healthcare. Like I said in the beginning, there are still things being written on paper, and there are still a lot of technologies now present where the doctor's prescription that he has written on a template can be uploaded and can also be used as data. So I would say it is still better, but it is going to be a challenge, more than capturing of the data, which is now getting addressed in various ways. It's important to know whether all the relevant things are getting captured and what are we doing about it. So the classification of data, deciding what is important to be captured and how it should be captured is the difficult part, as I see. Capturing will become better and better as we go. So classification and ensuring what is important. There is capturing a whole lot of information is not useful. It's that capturing that 5 things that is more important. So that is where the things become a bit difficult, and that's where again technologists have to work with business and clinicians to arrive at what is important. Let's not go and capture a lot of garbage uh, just for the sake of filling a form.
Okay, thanks, Vineet. Now, SJ, I know you've been waiting to come in. Come in.
Yeah, no, just two things. Firstly, I want to address the issue around data, and the second about privacy and the fear around misuse. So on data, let me share two practical examples. But I'm not claiming it, but I want to first narrate it, right? So if you look at Zebra, we have like close to 500 million images from Clalit, which is the world's second largest HMO, from Intermountain Healthcare in the US. So we're sitting on probably one of the world's largest repository of data. Okay. Now we've built algorithms on this on a very mature data infrastructure. When I use these algorithms in Japan, in Brazil, in India, in Africa, they work equally well, even though maybe there was not good representation of maybe Indian, Japanese, or Mongolians, etc., in my original data set. And I'll come to this more in a second. In fact, the performance sometimes is even better than what we saw locally. Second, there was a recent study done by a South Korean company, which basically had all its data from South Korea, and it was deployed in the Swedish, Finnish, the Scandinavian countries. Again, the performance was great. The point I'm trying to make is when it comes to radiology and imaging, because probably, and I'm not claiming this, but I'm just saying probably because it's about the anatomy, and because the manifestation of intracranial hemorrhage or the manifestation of a calcium scoring on the heart, the cardiovascular calcium scoring, Agatston, etc., are similar in different geographies or different populations, these algorithms somehow seem to work well. Now, I'm not saying that this means we should be satisfied with what we have. I agree with Professor Fanindra that the data sets are very homogeneous, but somehow it's working well as far in this limited set is concerned. Okay, the only thing, I'll add one more point. In my experience, I have found people only talk about demographics, gender, and stuff like this. What I have seen in AI is the technical variations actually matter more. So have you got enough images from Siemens and from Hologic and from Shimadzu and different manufacturers? Have you got enough images or training sets which include the inclusions like 2 millimeters or 2.5 millimeters, 5? So I'm saying the technical variations actually, to me, are making a big difference in the algorithmic performance more than the demographics sometimes, but this needs to be proved. The second point on data, I agree with Sharif that there is risk. For example, I saw an article in the New York Times, I don't know, somewhere about Mayo Clinic doing a deal with Google, right? Now, so data is being shared by a hospital with a tech company, right? And it's happening, and we need data to move forward with science. But who owns this data? So if I am the patient, I own the data. The hospital says, I have anonymized your data. So there is no PHI, there's no PII. So suddenly, does it become the hospital's data? This is unclear, right? But I need data to move science, right? I can't progress science without trials. But who owns the data? The first point. Second, I think there must be a way where the data must have a home. Today, the data is in a central cloud somewhere, which is easy to hack. If you go to Estonia, they are looking at a possibility of data being individualized. So each individual owns the data. But this is an area of concern. And Sharif, I agree with you. I'm hardly on Facebook. I don't even have an Instagram account. I think I've not been to Facebook for I don't know how many years. But yeah, it is a risk because we talk about privacy of data, but our behavior in social media is quite the opposite. So I fear about that aspect.
I'm not sure, SJ, you have children, right? You have how do they look at this behavior of yours? Because it's going to be very difficult to have this conversation with a millennial because
I think
the world.
no, so I also think that eventually the healthcare will have a Facebook-like platform where I can download an AI, download a PAX, download an EMR. See, today it's a headache dealing with one EMR company, one RIS company, one PAX company, one AI company, and it's a mess. But if I had a platform like Apple, and if I had an app store from where I can just download and it's all interoperable, that becomes easy. So I think it'll move towards that. But yeah, I don't know. But I'm not so much onto social media. Maybe I'm missing something, but I don't know.
Sanjeev, if
No,
I
no,
can
no. I
come in.
think SJ, you're doing the right thing. That's why you are able to do something more productive. If you were on Facebook, I think you would be at least 30% less productive. Yeah. It's such a wasteful of
Sanjeev,
platform, according to me. Yeah.
No,
Sanjeev,
it's
I
just
don't
that if I
think.
go to Facebook, I'll get depressed because everybody seems to be happy and having a great time. So,
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 Vineet, you were
Sanjeev,
saying,
I don't think any of us are qualified to talk about
correct,
social
correct.
media because we are too
Exactly.
old to
Although
speak
we are
about
not
it.
even
Uh,
there, so how do we know? I'm not there.
so, just coming back, one point which I wanted to make here is that
Mm.
it is indeed we have to be careful. We have to be, and on the ownership aspect, it is that's a much debated topic. I also am of the belief that the patient owns the data, but having said that, how do you make this available? There is a reason why this data has to be made available for research, for purposes. And it's a very thin line. So when somebody like a Mayo Clinic you gives it using the data for research for the benefit, it's a thin line. You can always decide, you can always say that, yeah, they are also using it because there is this lovely word called data monetization that also
Exactly.
creates a lot of, uh, I mean, it completely messes up the thing because I guess data monetization is a wrong word. Data being used for things that are useful. I don't know what is the right word to use that. Even artificial intelligence is the wrong word. There is nothing artificial about it. So there is, it's like
It's
it is
real.
more real. It is real. So so I'm saying yes, it is. While we have to be, it has to be a cautious optimism, or we have to be careful. We have to do all the right things. We have to bring in the only better part is because healthcare is still a regulatory area. That is definitely one good aspect because it won't get misused a great deal is what I hope.
No, so I think, Vineet, you brought this up earlier also, and I also feel that, it's not only healthcare. I think any technology, whenever it comes in, it comes first in the financial world. Then I have seen it moving into the retail world. And then somewhere here and there it moves into healthcare. I have personally seen, I think there is a lag of when a technology was introduced into businesses from financial world to retail to healthcare. There's generally a lag of 3 to 4 years. Now, this is coming down, of course, over a period of time, like everything else. But I actually personally do not regret it because here we are talking of life and death. If a drone delivers a packet at a wrong place and then after 2 days it goes back to the right place, I think it's okay. We cannot make those mistakes in patient and healthcare. So I'm pretty happy and comfortable with the fact that the technologies get tried or tested or become robust in the financial world and retail and come to healthcare, when they're kind of fully ready. But uh, am I being overcautious? Or I think this is not, it should come into healthcare as soon as possible and make a difference here. Because at the end of the day, the flip side is it is life and death. And I think we should have the best things coming in and addressing that problem sooner than later. So, Dr. Sharif, you are the one who touches the patient and you are closest to this scenario. What is your take on this?
Yeah, I do think that healthcare in the past has been very slow to adopt new technology. I mean, in terms of perhaps non-medical care. So in terms of medical care, we keep going up on the number of Teslas in an MRI, the number of slices in a CT scan, and all of those things. So that way, medicine is very advanced from in terms of technological adoption. But in terms of other things, we've been very slow. And I think we need to catch up definitely with other industries. And if you look at it, we used to say that every company needs to be a technology company and whatever company. And now we're starting to see technology companies really getting into health, and especially in this post-COVID era, we're starting to see that more and more. If anyone saw the launch of the new Apple iWatch 6, it was really all about health. And Tim Cook was asked, what will Apple's greatest contribution be? And if you were to look back 20 years from now, and they said in health, he said in healthcare. So I think there will be a greater merger of technology and healthcare. And at the patient level, it'll be through wearables such as Apple Watch. But I think that's just the beginning of what we're going to see as coming out there. And so we need to be able to now, patients are doing it. My wife got me an Apple Watch earlier this year, and I use it, and it's motivated me to exercise and lose weight. So, we're going to see more and more of that. And it's not only going to be about, acute illnesses, which is what we as health care organizations tend to focus on, but it's really going to be about health and wellness. And we need to shift our mindset a little bit also in terms of that approach to our customer, to our patients. So there will be a much greater integration as we go forward.
On the GPS, your wife is watching you. She knows your location.
I knew there was a hidden motive.
Okay, so going forward for a moment, I'm saying let's pause and assume that AI has moved to a level where we have the technology which has become robust. It's a product. It's addressed. It's one or two specific problems, and the products or algorithms are FDA approved. Now let's come to the, as we call it, rubber meets the road. Now I understand only radiology or imaging to a certain extent. Now let's say I have an algorithm, which can diagnose XYZ very well, and it has got all kinds of certifications and approvals. Now, if that algorithm, looking at images, gives a report which I have to sign, do you think I will sign it just because everybody else thinks that the FDA says it's done and dusted? I have a feeling I will not. I will see its report, I'll apply my mind to it, maybe 10 times, maybe 100 times, maybe 500 times. It'll depend on my conservativeness or, my level of, fear or anxiety before I start signing on this blindly. So now from all this, I have moved to the level of adoption. What's your take on this, Dr. Sharif? How do you, as doctors, will underwrite or sign on a document which is created by AI algorithms?
I think with any technology, it's going to take some time for us to develop a comfort level. But again, if it will come with time. So initially, I may take the same amount of time whether AI is looking at it or not. But over time, I think I will develop a familiarity with what the product is capable of doing, and that applies to any technology. So everything has its limitations. So that's why we've all said that it is a tool to supplement a healthcare provider. It's not a tool to replace a healthcare provider. So in terms of chest x-rays and a large amount of chest x-rays, they can rule out the big things. I may be able to look at a chest x-ray quickly that AI has already, and I say, okay, I don't see anything obvious there, go through the next one. So again, it helps me become more efficient, but it's going to take time for any healthcare provider to become familiar with and to use any technology, but that will happen. And I think with the speed at which these algorithms are improving, I think it'll just make our comfort level greater.
Yeah.
Okay. SJ, when you guys are producing this in Zebra, what are you keeping in mind from a adoption perspective? What are those few things you are doing when developing these algorithms that they are adopted quickly and
Yeah.
there's minimum resistance coming in?
Yeah. So I think so. Firstly, AI tools are basically statistical devices. They're statistical tools, and therefore there will always be some false positive, and there will always be some false negative. Right? You cannot have a system that doesn't have that. So, firstly, what we do in order to get the doctor's acceptance is that we explain why the false positives could happen, right? So, for example, in an intracranial hemorrhage algorithm, there could be a false positive because there's an implant or there's a meningioma or something like this. So they understand it's a black box, as Professor Fanindra said, but we want to kind of reduce the level of blackness in the black box. So, firstly, try to understand. This is the first one. Second, in order to adopt, we want to find out what the doctor wants. Does he want a system that is extremely sensitive, which means no false positives? Or does he want a system that is kind of more specific? Like, for example, there are some healthcare systems which say, listen, I don't want to miss anything, right? So then you can actually use these tools to kind of recalibrate so that their adoption is better. And finally, in order to adopt, it should not be intrusive like EMR. It should all be integrated in the backend. The doctor must not see the AI at all. It should just happen embedded in the PACS or embedded in the RIS or embedded in the EMR, everything on the backend, and the doctor never really sees until the analysis and the inputs and the insights are provided. And so if you look at the spectrum, as I said, detection of the disease, segmentation of the disease, quantification of the disease, and classifying cancer, no cancer, whatever. We have not reached the last stage because, as Dr. Sharif said, it is still the doctor who's taking the decision from a medical legal perspective. No AI company today is taking that medical legal risk, right? It's the doctor. But I don't think, but what I feel is that if you look at a radiologist's behavior, they may look at a breast image. In some cases, they may spend 10 minutes because it's difficult. It's a dense breast, there are multiple layers. In some, they may just take like a second to detect. So even two cases are different. So what we are now trying to do is to see how much time a doctor takes in the case when we actually do the training. So this way, an algorithm can actually give an insight which says positive for cancer, difficult case. So the doctor actually goes back. So I think I want to come. I want to see an algorithm one day which says positive, negative, and I don't know. Algorithm must be able to say I don't know, but it doesn't, right? Because it's not trained to say I don't know, or it must say I think it's positive, but this is a difficult case. And so the doctor knows, end of the day, the doctor has to decide, as a patient, I don't want a machine to tell me. I want to still talk to the doctor and say, okay, the machine has said I have cancer. Now tell me why and how do I deal with this?
Great, SJ. So let's thanks so much for this. But Vineet, I want you to come in and finally the last word I think will be with for Professor Fanendra, and we'll go back to him. But Vineet, what's your take on all this?
I think we're very much covered. So between Dr. Sharif and SJ, very much covered. So adoption, adoption is going to be only after. So when you look at you actually set it up by saying, Sanjeev, that it's been tested, it's gone through all the labs, it's been FDA approved, right? And then that's when the rubber hits the road, right? And for players like, I mean, service providers like us, and for people like me who enable the service providers with technology and uses, we would also work with clinicians and do proof of concepts and before we drive. So we don't go it will be foolish for any of us to just go and put a technology there when a clinician adoption isn't there. So they would have gone through that, but there will always be, like SJ said, there will always be false negatives and false positives. There will always be people within your organization who are averse to trying things new, who are very eager to try things new. Yeah, it's like, again, there are very few people still driving the Tesla, right? It is very much out there. It is I mean, we see so many cars. I'm sure Dr. Sharif and I in Dubai have got so many of our friends owning a Tesla, but Even then, the regulatory environment then comes in to say that you have to hold your hand onto the steering, right? And that is because the regulatory environment has not matched up to the technology that the solution provides, and therefore there are some safeguards put in place that if your hands are not on the steering for a long period, it will start beeping, and if you still don't put your hand, the car comes to a halt. So very similar analogy, right? We will bring up something based on the regulatory environment of which country it is being brought in. There'll be some of these rules that are tweaked, and there will be some people who will take the car and out there and drive and enjoy the ride, and there'll be some who will be initially very skeptical, very scared, and not even try them. And there'll be some people who will walk home, will not even use a car. So,
Correct,
so
correct.
but that's true. That's true in any case, right? So that doesn't mean that the technology is bad. That doesn't mean it shouldn't be tried. So I guess that's the spirit in which you should take all these. I'll repeat that AI is all about use cases, right? Getting the right use case, working with people and doing it. It's not to replace anything. It will continue to complement and complement very, very well. All the more because of its healthcare, and if it is tried, tested, it's going to make a big difference. I see a lot of good future for it. But I will not worry about how it is done, Professor Fanindra. I'll leave the how it is done to you. I'll rather just
No,
know that it's been done properly and I'll use it.
no, so I'm now looking at the watch also. I think we are running just about a few minutes away from the end game. But I want to come back to Professor Fanindra because, we in the industry, in the hospital, as the users, as CIOs or CEOs, I think sometimes maybe dreaming, imagining for the things to come. Here is academia, who knows exactly, what is possible, what is not possible, what are the challenges there, and when will it really come out and be able to touch and feel the society at large. So Professor Fanindra, where are you? What is the road ahead? And while you are talking about road ahead, I know you are a straightforward man. I'm sure you will also share some not so good stories where things have gone wrong with AI, and how you as an academia are ensuring that those failures are minimized going forward.
So one thing is, first I will start with a suggestion. And I would strongly suggest everybody to read this book called AI in Healthcare by Dr. Parag Mahajan. It's a very
Okay.
light read.
Mhm.
He's a radiologist who has written this book. I have read it. It's a beautiful read. So
Mhm.
one thing which I want to tell is that Dr. Mahajan makes it as a very beautiful point. He says that if at all assume that all that has happened and everybody has approved, it is going to be treated like a laboratory test. Does every doctor refer to every laboratory test? No. So the doctor has certain comfort with certain laboratory tests, and they are going to refer to certain tests which they have very good confidence. So even assuming that AI is going to do all and all, but it's still going to be referred as a test, as comfort of the physician or the radiologist, or for that matter, the clinician. That is number one. So the number 2 point which I wanted to mention, I think this is already touched upon. Every technology has a plus and a minus. And purely working from the academia point of view, we would like to solve the hard problems, because the reason is that we would like to look at maybe 20 years down the line, or we may not even see the light, which is fine, because we are not really interested in maybe solving the societal problems. Most of the time, we are interested in solving what is an interesting problem. So the interesting problem could be defined many ways: mathematically challenging, scientifically challenging, even societally challenging. But we are mostly interested in mathematical and scientifically challenging problems. But having said all this, I can only give one example, and anybody can look it up. There is a nice website called Medical Decathlon. It has various data sets which are curated. So this is just detection of some of the tumors. And all they have put up a challenge is, can you develop an algorithm, for example, assume that you are able to detect brain tumors. Can it also look at the lung tumors? Can it do both? Right? I can tell you the leaderboard is not really big. We don't have really the technologies which can do both. Right? We can do one at a time, right? Or we can tweak it so that we have back-end detection that, okay, this is the lung image, now we want to detect the lung tumor. Right? It is not like a radiologist who can do instantaneously. So there is still a long way, in my view, to make it as a, like what Vineet has mentioned. It is all about use cases. Can I come up with a very big thing where we can make a difference in terms of making the doctor's job more pleasurable? I think it is going to be more in the space of making the doctor's job easy rather than making it as a standalone and doing something in that space. And I just don't want to equate it to the EMR and EHR because EMR and EHR is only a pain point. And possibly, I will say that it's going to be more of using something like, you having a remote rather than physically going and switching on the TV. So it's a
Correct.
pleasure.
So thank you so much, Professor Fanindra. Now I'm just doing a time check with Mr. Swapnil. Swapnil, are you there still? Swapnil?
I see him there.
Yes, sir.
So
So there
are
are two
we?
questions from the audience. So if you could just
Okay, okay.
put it in the chat.
Why don't you only read it out here? Come on, you read it
So
out.
there's one
I'll do.
question from Mr. Sahasra Buddhe. So we
Okay,
have done to be a .com global experience a decade ago.
okay. And the other one?
The other one is long.
Okay, so let's stay with this. So who wants to take it? This bubble.
Sorry, can you repeat the question? I didn't get that.
So with AI turned out to be a .com bubble experience a decade ago.
It's going to be a .com bubble. We are far away from it. Today we have Alexa sitting on our homes. So it is not going to go away. So it's going to stay forever.
And Google navigation maps are anyway there every day, all the time.
If not, people are thinking that it's going to go away and the bubble is going to burst, it is not.
No, now that Professor Faninza, you brought up this mention Alexa, what is this story going about that Alexa, while it's in the room, is recording everything which is happening in the room, and that's the privacy and the fear sentiments coming in.
Well, I can only answer this saying that every technology, like what Vinith has mentioned, it is like going on the road. Comes with plus and comes with a minus. You choose what is best. Somebody was mentioning about the iWatch or Apple Watch. I can only tell you that it might give you a bit of a fear for you if something goes wrong, which may not be. Right? So as a doctor, you might be comfortable in wearing it because you know the science. But as an individual, I might be a little uncomfortable in wearing that
No, but
because
it's just staying with that Alexa thing because I had a grandson who I have who's just gone to US and we had got him an Alexa. And when it was in the night, we were playing around with it. There were so many questions coming in. Hey, switch it off before you sleep. Make sure you're not doing this. And so all the fun which we used to have with Alexa went away after a few days of playing with it. So is that all real or imaginary?
no, I am not sure, right? So I can't comment on whether it is real or not. But today, by it is a very fine print, but you are giving permission for it to record. You can read it very clearly.
Okay, okay.
Once you have an Alexa in home, you are giving permission for it to record everything, and it can be used only for internal purposes. But still, somebody is capturing that data.
Okay, thank you. So what about Swapnil? Second question?
So this is from Dr. Abdul Bhaya. So he is asking, as a
Put it on the
clinician
chat.
and radiologist, I have put it on the chat. So in case anyone would like to take it, especially Mr. Jairam, it is
Yeah,
Yeah,
yeah.
it's for SJ.
Okay.
So I think so, Dr. Baya. Let me just how do I maximize this chat? It's just such a small. Okay, 1 second. So typically, I think so. Two things, Dr. Baya. Number one, we do a lot of work to actually publish some of our findings, whether it is osteoporosis or cardiovascular or liver or whatever, in in top deck journals, which are peer reviewed, like Nature or some of the biggest journals, right? So if we are able to publish our study in some of these journals, which are peer reviewed, this gives a lot of credibility, number one. Number two, all of these, so what we do is you have data, because we have a large repository, we also test the algorithm outputs with what is known as a ground truth, and that can be with three radiologists, both certified radiologists. So obviously, these algorithms are tested and stress tested against some of the best minds out there. and then there is a lot of science to support it. So based on this, I think nobody's and of course FDA will not even allow if the algorithms are FDA approved, you can be reasonably sure because it's not easy to get an FDA 510K. Even though I think they're going to be making the standards more stringent. I can't read remote. Yeah. Yeah. So, and also in terms of curation, actually, we spent 2 years only curating the data and data infrastructure, even before we started actually working on developing and deploying them. So I agree with you on the curation, establishing the ground truths, making sure that the data is fairly diverse, both technically and demographically. And then you also have to test it against the wild, which means outside the data that you have used for building and tuning.
Swapnil, anything else?
No, sir.
I actually have a question for the panel, if that's okay, Sanjeev.
No, please, yes.
Yeah, I've talked about AI technology from a doctor's perspective, from a healthcare organization perspective. Globally, one of the greatest challenges in healthcare is resource distribution. So there's tremendous healthcare resources in urban areas, in suburban areas, but lack of access to healthcare in rural areas, and therefore early detection is not possible. Clinical outcomes are potentially worse. Can technology, can AI be used for earlier detection rates in these rural areas so that earlier diagnosis can be made and people who may not have that access, same type of access to healthcare, but through implementation of technology, receive the care that they need?
Yeah, great. Thank you so much, Dr. Sharif. I think these could be the last comments. I think we've run out of time. Swapnil, do we have to close it now? And if we are, I want to thank Dr. Sharif, Mr. Vineet, Professor Fanindra, and my friend SJ for being here. And I also want to thank CII and Swapnil for giving us this platform to have the discussion. Just one last word. Has Mr. Joy come in the meanwhile?
No, sir.
No.
Yeah.
Okay. All right. So I think we can close the session with permission from Dr. Sharif. Yeah. Is that okay, sir?
Absolutely. Thank you so much for having
Okay.
us.
Okay. Thank you, everybody.
Everyone for joining us. Thank you.
Okay. Bye-bye.
Thank you.
Bye.
Thank you. Bye bye.
Bye.